Dr. Shailesh Hadgaonkar. I'm grateful to both of you for arranging this very relevant program on a very auspicious day, which happens to be the World Osteoporosis Day. As we are all aware that osteoporosis is a major burden of disease across the country, and with our growing population of elderly people, we are going to see a lot more of these problems in our daily clinical practice. And the good news is that over the last couple of decades, we've gone a long way in enhancing the medical treatment of this disease, as well as surgical aspects have really grown up. And over the last couple of decades, we have really seen big advances in the surgical management of these patients. So we now have solutions to a lot of problems which we did not have in the past. And I'm sure there are many products in the pipeline, as well as many molecules in the pipeline, which is again, I thank all of you from the core of my heart, because this program is going to be a great success, I can assure you. I'm handing over the mic to the next speaker with again a word of thanks to all the faculty who've joined, and my special thanks to Dr. Arvind Chhabra and Dr. Shailesh Hadgaonkar.
Thank you, Basu sir, for your kind words and great support for this academic initiative on World Osteoporosis Day. I just would like to start with a case. Let's head to a case and see what we all feel about this. This is a 72-year-old lady, dorsal pain, mid-back pain, no leg pain. She had a fall 1 month back and persistent pain, not getting better with medications. And this is what is the X-ray. I would like to ask Chhabra sir, how you will treat this patient?
Shailesh, if I got you properly, this was an injury 1 month back, and the patient has severe pain which has not responded to treatment, right?
Yes, but her back pain was more than a month, but that fall precipitated her pain.
Back pain has been there from before, right?
Yeah.
So,
yes.
I would definitely try to give conservative treatment at trial, because in the dynamic X-rays, as we can see here, though there is opening up and there is some instability, but I can't see any gross instability per se. I will give a conservative treatment at trial. I will evaluate her for osteoporosis. I will do all the lab tests to rule out secondary causes of osteoporosis, do a DEXA scan, and manage her conservatively. If the conservative treatment fails, a good conservative treatment fails, then I will consider augmentation in this patient.
Okay, sir, this patient, when she came, that time this MRI was already done. And this is what was her presentation.
The age, what did you say was the
72, age? 72.
72. So 72, at the age of 72, I would, I would want to also confirm with the PET scan if we are not messing out on something.
Perfect. Dr. Arun, how will you treat this?
So, more or less, it will be similar to what Dr. Chhabra said, except that at 1 month, usually I counsel the patient that now that it is 1 month and the fracture is still not healed and you are still painful, maybe you will have to consider undergoing a procedure. If you are not able to tolerate a period of immobilization and suffering pain despite medication, then there is a possibility we can do a percutaneous augmentation even at this stage, but still leaving the choice with the patient and attendant at this point of time. Not an absolute recommendation, but a relative recommendation depending upon their desire to get pain relief.
Perfect. Suresh, will you consider giving her a brace, like fiber molded jacket or a tailor's brace, or you would like
to? No, I won't consider giving a brace, because it is the vertical loading can't be prevented. Only the forward bending may be prevented to some extent. I would rather go with the rest of my Chhabra sir and Dr. Arun, but they have told conservative treatment.
Okay, let's hear it from Siva. Siva, what is your protocol in such cases?
Yeah, it's interesting. I agree with everything that my colleagues here have mentioned, but interestingly, in the United States, I think we are more aggressive with bracing. So typical protocol would be to put a patient like this in something like what we call a TLSO brace, thoracolumbar orthosis. But Dr. Pillai's point is a very good one, which is that it's really vertical loading that is the key, not and the brace may not help too much with that. But sometimes we get upright X-rays without a brace, and if we don't see any progression of kyphosis, sometimes we just do a soft brace for comfort. But most commonly, surgeons will provide a hard, clamshell type brace for this patient.
And if you see that there is some amount of pincer at D11, the cord getting, pinched.
Yes.
Will you consider only brace, or will you consider any procedure?
Oh yeah, I think if the pain is refractory or it's too severe, then definitely augmentation would be in the cards. Yeah.
Will you consider augmentation or fixing this instability?
Yeah, fixation also definitely reasonable, but I think the threshold would be higher, especially if in the absence of a neurological deficit, and we would probably still try augmentation first.
Perfect. So I think from here, because there are a lot of things which have come up from Dr. Chhabra to Dr. Siva, and we all are seeing that there are different things, as we see these different aspects of the investigations, blood and all this. I would like to invite Dr. Varun Agarwal to enlighten us with the investigation protocol. Varun.
Thank you, Dr. Shailesh. So if I can share my screen.
Please.
Yeah. So I'll be talking a little about the evaluation of such a patient. I hope you can see my screen.
Yes, Varun. Perfect.
Yeah. So when we talk about the evaluation, we should remember the evaluation of the patient starts from the history itself. And we should focus on the risk factors when a patient of this age group presents us with a chronic back pain or even an acute back pain. We should be looking at the age, the low BMI, ethnicity. Caucasians are more susceptible than Asians, and least in the Africans, and if there is a family history of the fracture. Others, such as a low estrogen or testosterone, which is very much neglected by us orthopedicians and neurosurgeons. And such a patient should ideally have an endocrinal workup as well. Low calcium and vitamin D levels, inactive lifestyle, excessive alcohol or cigarette smoking, all these are the risk factors. Hyperthyroidism, GI conditions, use of steroids or proton pump inhibitors for prolonged durations, all these should be elicited and looked into. So these are the various risk factors with a useful mnemonic known as ACCESS: alcohol use, corticosteroid use, calcium, which is low estrogen, smoking, and a sedentary lifestyle. So when we talk about the laboratory diagnosis, we should be looking at creatinine, calcium, alkaline phosphatase, assess for the renal function, and the choice of treatment which we can subject the patient to. If there is low calcium, we can consider repleting it. Too high, consider the possibility of hyperparathyroidism. Then alkaline phosphatase to rule out osteomalacia or a Paget's disease. Vitamin D and 24-hour urine calcium if that is available. Then parathyroid, testosterone or estrogen levels, 24-hour urine cortisol for Cushingoid features are there, especially in the patient. Then these days, DEXA scan, which is a dual energy X-ray absorptiometry, which measures bone mineral density and approximation of bone mass, and it is the best predictor of fracture risk. Standard deviation of a normal young subject is manifested as a T-score, and age match, which is mentioned as a Z-score. So it is
Varun,
used.
can I interrupt you?
Yeah.
How often you consider doing a DEXA scan in a patient who is coming to you, elderly, 55, 60-year-old lady with back pain and X-rays looking like she has osteoporosis?
So DEXA scan is a useful tool if it is available, and unfortunately in my setup, in my city, it is still not very popular or available, but it is a good indicator and a good measurement of your response to therapy, that whatever medical management you put the patient on, what is the response and how you judge it.
Given a choice, you will strongly recommend this.
Yeah, sure.
Okay, perfect. Please go ahead.
Yeah. So it helps us to detect the risk for bone fracture, confirms the diagnosis of osteoporosis, determine the rate of bone loss, and most importantly, determine the response to therapy, the medical management which we put the patient on. So this is how it looks like. This is the DEXA machine, and this is the kind of a report which we receive from the radiology department doing the DEXA scan. The T-score, post-menopausal women and men, used to determine if the patient has osteoporosis, and the Z-score, pre-menopausal women, used to determine bone mineral density. So this is how it looks like. Osteoporosis with a T-score of less than minus 2.5. And minus 1 to minus 2.5 is the osteopenic range. So this is how we can work up the patient. And other risk factors like Dr. Chhabra mentioned, PET scan and all for any additive pathology to distinguish pure osteoporosis from any other causative agents which may have predisposed the patient to the risk factors.
Very nicely said, Dr. Varun, and you really covered the topic in a very good time. I think whenever the patient comes and you are in doubt, clinical history is very, very important. And that can give a different perspective for thinking whether it can be a myeloma, because that is reasonably commonly seen in spine practice. The first thing what we always think is whether it is osteoporotic fracture, are we seeing the fluid cleft and signs, is the patient is having any other associated issues like any history of cancer, because metastasis also is common, and some of the cases we have seen lymphoma also behaving like osteoporotic fracture and was treated with osteoporotic medication. Yes, Arun.
So very nicely summed up. Just one small observation. Sometimes you see females in their late 40s or 50s and you do not suspect osteoporosis, but one important history of hysterectomy at a young age is a thing that one should not miss out.
Very, very, very rightly said, because that is a very important thing. A lot of females do have hysterectomies in the late, early 30s, and they have chances of osteoporosis in an early age. Also, something called as PPSO, the postpartum spinal osteoporosis, is a term which is described in the literature, where we have seen very rarely, it's not common, but young girls, young females, 20, 25 years with deliveries showing osteoporotic fractures. And they are the few interesting aspects in this, and we need a proper evaluation for these patients. Perfect.
And some other people with those who need steroid therapy, like asthma, then rheumatoid arthritis, SLE, these young people also get osteoporosis and compression fractures very often.
Absolutely. Very true. Postmenopausal and senile is common, but these are the things which are additional where we have to be careful to assess the patient well. Thank you, Dr. Varun. We proceed with Dr. Bhave's case, Dr. Arvind Bhave. We are planning for mixing a topic and interesting case so that we can proceed. Dr. Bhave, sir, please share your screen. Yes.
Okay, good evening. I'm sharing this standard routine case, which most of us are seeing in our day-to-day practice. A 74 years female patient who was diabetic, hypertensive, had angina, and also had urinary infection. She suffered from fractured spine while traveling in a bus from Pune to Mumbai. And Asiad Bus is very famous on this part of the country. And then at Mumbai, she was given conservative treatment in the form of bed rest, calcium supplements, control of her medical problems, and brace as and when required. And this happened in April to July 2003. And this was her picture. This was the first picture, just minimum compression, as you see here. That time, the conservative treatment was given.
Sir, you need to...
the next thing, this is a follow-up. Yeah, and this point, she has developed a collapse with a small cavity inside. You can see.
Sir, sorry, it's not seen on the screen. The next slide.
It is not getting shared? I think.
No, it is shared, but case 1 is seen. You need to...
this one?
So you need to go to the presentation mode on the bottom right. There's a presentation mode. So in the PPT itself, slide.
Okay. Yeah, I have gone actually. Okay.
Or you can just put the cursor.
Okay, here, can you see? It has not gone in. Okay.
No. Yes, now it is seen. And you can put a PowerPoint mode.
Yeah, it is in PowerPoint mode. Can you see?
Yes, we can see. But you can enlarge also, sir.
So make it presentation mode.
In the PowerPoint, yeah.
Yeah, now it's better. Yeah. Oh, just on this side. No. One step left.
Yes,
this
correct.
one.
Yeah.
Okay, I think we can proceed. That's not a problem.
Yeah, okay. So at this point, we have done her vertebroplasty. You can see the avascular cavity which has been properly filled. And these are the X-rays post-operatively, post-vertebroplasty.
Sir, you need to go to the next slide, please.
And this was her clinical presentation. Patient had gone, she did even Chardham Yatra also. And she came.
Bhave sir, sorry to interrupt. You need to move to the next slide.
You need to manually go to the slide, sir. It's not showing automatically.
Manually?
On the left
panel.
Yeah.
Go back, sir. One more backwards.
This one.
This one. Yeah. Now Now it is seen.
So I will go on the PPT mode.
Yeah, the right one, sir. Just right to what you are pressing. This big one. Yeah, single. Just press it. Somehow it is not opening up.
Or should I start new share? Okay.
No, sir. I think this is okay. It's all right.
Okay.
Yeah, this is okay. You can just scroll the left side when you're talking about the slides. Yeah. This is okay, sir.
Yeah. So this was her clinical picture. You can hardly see any scar over here. And this lady performed even Chardham Yatra.
No, sir, you need to. Sorry, you're not. The next picture is not clicked. You're talking about that scar, but we have
you need
vertebroplasty picture.
Scrolling from the left panel each slide whenever you switch.
Each slide, you'll have to scroll from the each slide when you are talking.
One by one from the left panel.
Okay. And this is 5 years follow-up. Can you see?
No, sir. Sir, no. You need to.
Yeah.
That is not that brown thing should come to the slide.
No, I'm not. I'm seeing something else actually.
Now you've gone ahead. You wanted to show the scar. You can just go back to one slide.
This one?
Yes, correct. Yes, sir. Now we can see that lady clinical picture and the vertebroplasty picture. Yeah.
So, and this is a 5 years follow-up. There is no collapse, no adjacent fracture. So, Kuhlmann's disease or avascular necrosis is a classical indication for vertebroplasty.
Perfect. I think in a very simplistic way, you have shown that vertebroplasty is a good answer for pain relief. And can you enlighten us on what is the mechanism, sir, how the pain relief occurs in vertebroplasty?
Yeah. The cavity which is causes sort of instability inside the vertebra. and that causes a lot of pain because of the movement of the fracture fragments. Also, there is collection of the fluid that makes spinal instability. So at this point of time, what we do is we stabilize by injection of cement, which is supposed to have empirical function in the form of stabilization of these fracture fragments. Second is the thermal energy, what is released, or temperature which is released because of polymethyl methacrylate, that is high, and that causes burning of the adjacent nerve endings, which cause pain. So that is also, in addition, one of the theories causing pain relief. So stabilization and the pain nerve pain sensation is reduced. These are the two main mechanisms by which we stabilize the fracture, and that is how patient's pain reduces.
Very well said, sir. I would like to ask Siva. There are a lot of papers and people are talking about what is the fate of the vertebral cement. Vertebroplasty is a procedure started by a French radiologist in 1986 for a tumor, and now we have reasonable data. But what is the fate of the cement? Any inputs, Siva?
Yeah, thanks. It's a good question. Honestly, in the US, we don't really follow these patients longitudinally for many years. Actually, interventional radiologists are doing most of the vertebroplasties in the United States now. It is actually sort of the surgeons have actually given up many of the vertebroplasties. So I personally don't have a great sort of long-term follow-up, either like clinically or radiographically. So I may not be the best one to answer, but I will say geographically and culturally, it's probably not a good thing in the United States that we have sort of given up a lot of vertebroplasties to the radiologist, because it's a great procedure. But maybe some others may have a better idea of what happens long term.
Yes, Arun?
Yeah. So, personally speaking, it's been quite some time since I did vertebroplasty. Most of my cement augmentations are kyphoplasties nowadays, for the sake of additional safety that I feel is inbuilt in the kyphoplasty procedure.
Okay. Yes, Suresh?
Yeah, routinely I don't do vertebroplasty, but in indicated cases, it is a good procedure. But mostly I don't do the vertebroplasty.
Chhabra, sir?
Yeah, I would prefer to do a kyphoplasty because the chance of cement embolization, cement leakage, either local or distal, is less with a kyphoplasty procedure. But some patients who can't afford, because kyphoplasty is a more expensive procedure, but would want to mention that we can get kyphoplasty kits quite cheap now, and you may not need to do it with double balloon. You may do with a single balloon and still preserve the safety. But if the patient still can't afford those subsidized costs, vertebroplasty is a good procedure which can be safely done.
Perfect. Dr. Chhabra, sir, this Dr. Bhave's case is 2003 and 5-year follow-up at that time. So I think that time mainly this procedure was in vogue, and nowadays, yes, safety is slightly more. If you see, because the balloon gives you the scaffolding a proper shape where you can put your cement, and we have better quality cement also which has come. So I think all these things are adding safety, and the price is also reduced quite significantly in kyphoplasty. Thank you, Bhave sir, for this interesting case. We would like to invite Dr. Nishad to just enlighten us about the current classification. Is there any classification or what it is? Nishad, over to you. Dr. Nishad Sidhu.
Thank you, sir, and good evening to all the eminent faculties. I'm very much honored to be here with all the stalwarts. So I'll be sharing my screen now.
Yeah, this is a recent classification, and let's see what Nishad has to say.
So I'll be talking about the fracture classification, which is given by German Society for Orthopedics and Traumatology for osteoporosis. So coming to the highlights of the classification, it was studied on 707 osteoporotic fracture, the fracture anatomy, and it was done in multicentric level. Insufficient fractures, maybe traumatic and atraumatic, both the type of fractures were included in this. And for diagnosis, they included all the three classifications, including X-ray, CT scan, and MRI. So this is the overview. They classified it into 5 types, OF1 to OF5. Now coming to individual types. So coming to the first one, OF1. So in this, on X-ray as well as on CT scan, we do not see any pathological findings. On MRI, on stir images, we see hyperintensity. In the image which is there on the right side, we can see that on CT scan, there is no fracture line visible. However, on stir images, we can see hyperintensity on MRI. Coming to the next one is OF2, where some deformation we can see either superior end plate or inferior end plate. Few times posterior wall may also be involved, but very little. So it can be classified as impression fracture, where mainly superior end plate is involved. On the CT scan also, we can see that inferior end plate, posterior wall is intact. However, superior end plate is fractured. The third one is we can label it as incomplete burst fracture, where superior end plate along with posterior wall is involved. And this has potential of collapse in future. Coming to the fourth one, this can be labeled as complete burst, where superior end plate along with entire posterior wall fracture is involved. It can be classified, pincer type of fracture can also be classified into OF4, where both the superior as well as inferior end plates are involved. In the CT scan given on the lower side, we can see that both the end plates along with the posterior wall fracture with retropulsion of the fracture fragment. On the fifth type, they specifically classified the fracture where distraction and rotational injury is there, along with the complete burst fracture where posterior ligamentous complex is also involved. So the guidelines which are given by this study group is that OF4 and OF5 in this type, definitely surgical management is indicated. In OF1 and OF2, it is essentially stable fracture which can be conserved. In 3, both the line of management can be tried. In case of increase in the kyphosis and collapse of the fracture, surgical management can be opted. Thank you.
Perfect. Thank you, Nishad, for a wonderful presentation. At least we all know this is a very recent, I think 2019 classification. Until date, there were various different classifications, but this is really coming for the treatment protocols, and I think it is widely used nowadays. Your inputs, Chhabra sir, on this classification?
No, this is a classification which has been validated also recently, and I work with Dr. Schnake in the AO Spine Knowledge Forum Trauma, where we have done this, and this is the most accepted classification as of date across the globe.
Perfect. Thank you. Thank you, Nishad, for a wonderful presentation and at least enlightening us about the current status. I would request Dr. Varun to present this case, which will be followed by Dr. Bhushan's medical management. Over to you, Dr. Varun. Yes, Varun, any issue?
Sorry, is it not showing?
Now we can hear you, and you can share the screen.
Who has fracture for more than 1 year? There are
so is it audible now?
Disc herniation or a spinal stenosis.
It is audible. You can now share.
There is a radicular pain related to a disc herniation. All these are poor.
No, it is not shared. The screen is not seen, Varun.
last match में chasing.
Hello, sir.
Yes.
Yes, sir. Please click on share screen.
Yeah, so just wait. I think there's some technical issue. I'm just sorting it out.
Should we ask Dr. Bhushan to,
All the participants attending this talk and ASSI for inviting me for this lecture. I am Dr. Varun Kumar Agarwal, Associate Professor of Orthopaedic. So before we move on to the procedure, we should know how to select a good candidate for kyphoplasty. The patient who tends to respond best are those who have 1 to 3 levels of fracture. There is a focal pain and tenderness corresponding to the level of edema on MRI. The fracture is present for less than 2 months. There is a recent worsening of fracture and there is no sclerosis of the fracture. A poor candidate is the one who has fracture for more than 1 year. There are other causes for back pain such as a disc herniation or a spinal stenosis or facet or sacroiliac joint disease. There is a radicular pain. So these are the instruments and how to set the table for the procedure. We use 13-gauge bone biopsy needles and we use lower lock syringes so that we can have a good fixation of the syringe to the needle and there is no leakage of any substance. We do the process under IV sedation or local anesthesia in which we use 1% lignocaine with adrenaline and 0.5% bupivacaine on the bone. General anesthesia is rarely reported. So the main advantage of local anesthesia is that it allows the surgeon to communicate with the patient and to determine the cement injection speed, anticipate any corrective measures that need to be done and abort the procedure if any problem is happening on the table. While the local anesthetic is acting, we give an injection of antibiotic along with painkillers and Perinol preoperatively. And personally, I prefer to use a nasal cannula as I find an awake patient is more acceptable of a nasal cannula than an oxygen mask patient. The patient is monitored and IV lines are established. There is continuous intraoperative monitoring with ECG and patient in the room is set up. The patient is to be placed in extension using radiolucent surgical tables or even bows. The patient is placed prone with padded rolls and the lower legs are also padded to remove pressure from the fracture and to prevent any soreness. Make sure that the patient is lying comfortably and stable. And prior to the skin incision, always check that your fluoroscopy is adequate and you can visualize all the bones properly. The patient is prepared with meticulous sterile technique. One should not treat it as a casual OPD interpretation. So this is the true AP image in which the pedicles in the upper half of the vertebral body, the spinous process is equidistant between the pedicles and the end plates are parallel. So similarly, a true lateral view is needed in which the pedicles are superimposed on each other and the end plates are parallel. So this is a short video of the procedure.
So as you can see, we just put the Jamshedi needle under fluoroscopic guidance in the AP and the lateral.
75-year-old lady with pain in the back and bedridden for 4 months with an osteoporotic compression fracture at L1 level. So local anesthesia is given and a Jamshedi needle is inserted. The pedicle is targeted under AP view and it is slowly advanced after confirming in the lateral view. The needle is again advanced to be in the body. And once it is placed in the body, then we remove the stylet and place a guide wire and exchange this Jamshedi needle with the working cannula. We can gently tap the guide wire so that it doesn't displace us. And now we remove the Jamshedi needle. carefully, not to displace the guide wire. You can hold the guide wire with the help of a forceps. And then the procedure is repeated on the opposite side. Local anesthetic is again given. And the Jamshedi needle is first placed in the AP view and then confirmed in the lateral view. And when you have adequately cannulated the pedicle, you can again put in a guide wire and exchange the Jamshedi needle for the working cannula. You can aspirate the edematous fluid in the fracture cavity, which is seen on the MRI, which confirms that the needle has been placed in the correct position inside the vertebral body. And you can send it for biopsy or culture. Another tip is to inject the normal saline in one needle and it comes out of the other needle, which confirms that both the needles are in the correct position inside the vertebral body. And then you can just aspirate this normal saline to make the cavity dry again. So next is to inject radio-opaque dye to confirm whether there is any leakage or not. And if the dye is well contained inside the vertebral body, one can be reasonably sure that the cement is not going to leak. To economize the usage of cement and use the same packet of cement in multiple vertebrae, one can take out the cement powder in a 50 ml syringe and the liquid monomer in another 20 ml syringe, so that we have 1 ml liquid for every 2 milligram of the powder. And so in this video, I've taken out the powder in a 50 ml syringe and empty around 20 milligram of that powder at one time in a bowl. This allows us to be very precise in the measurements. And a 20 milligram of powder is emptied into the bowl. The rest is set aside to use subsequently in another vertebra if it is needed. And set aside the powder for a subsequent procedure on the next vertebra. Post-operatively, the needle site is dressed and there is strict bed rest for 2 to 3 hours with monitoring of the vital signs and a neurological. The patient is discharged 3 hours after the procedure and follow-up is done on the next day, 1 week. So my protocol for these osteoporotic compression fractures is I do it in cases less than 6 weeks old who need to be hospitalized, or there is a failure of conservative treatment after 3 months. I choose vertebroplasty for all, except when the middle column is involved, I tend to go in for kyphoplasty. However, both of these procedures must be treated with the respect, as its application without appropriate preparation and physician knowledge can quickly produce increased pain, permanent neurological injury. Thanks.
Yes, Varun, wonderful presentation. I felt like I'm watching a winning IPL match. Flawless, dobara mat puchna. एक ही बार देखने के बाद में I think everyone can understand principles, how we should do it, and in case if there is a difficulty, we can refer the patient to you for kyphoplasty.
Thank you so much.
Yeah, Arun, quick comments.
No, he explained it very nicely, and well done procedures, and as he already said that you cannot take them lightly even when they look excellent in the expert hands. There have been cases where cement leakage has played havoc, and one should be watching each fraction of a milliliter of cement while it is being injected in the C-arm. And at the very first incidence that you suspect a leak, you should abandon it rather than pushing your luck in segmenting at that vertebra. That is the only word of caution that I would add.
Bhave sir, quick comment.
Yeah, fantastic video presentation. I think everything is self-explained very nicely. So congratulations, Varun.
Thank you, sir. So I have a comment. Actually, I use a vertebroplasty cement, which is a little delayed setting cement. So actually, you have very much control.
That gives you more time to manipulate also.
More time and more control over what you are doing. So just fill the anterior 1/3, wait for a while, then go back,
for
middle 1/3, and then subsequently fill the last. So it gives you a little.
Usually, I don't fill the posterior, so chances of leak are much reduced. And main weight-bearing column is middle column and anterior column. So you may not do anything for the posterior column.
Yeah, and nowadays, recently we have done a couple of cases of this vertebral body stenting, the stentoplasty, that is come in India, and that is also showing very good restoration basically in selective cases, not for all, but kyphoplasty stands tall today for sure in most of the cases. Thank you, Varun. We move on to the next presentation. Medical management of osteoporosis is one of the very important topics. And Dr. Bhushan Patil will be presenting this talk today. Over to you, Dr. Bhushan.
Good evening to all the eminent faculty. I am really honored to be able to present, given an opportunity to present in front of the national and international stalwarts. I'm sharing my screen now. So the medical management of osteoporosis. First, is my screen visible?
Yeah. Perfect.
Okay. So first, before treating the osteoporosis, we should understand which patients need to be treated or which candidates are suitable for treatment. So this flowchart really explains it well. Any woman more than 65 years of age or any man more than 70 years of age needs to get a DEXA scan done. And if the T-score is less than -2.5, or if the patient has a history of hip or spine fracture, then the candidate is definitely up for treatment. Or if the T-score is between -1 and -2.5 and there is an increased fracture risk, then we have to do the FRAX assessment tool, the 10-year fracture risk probability. And if the hip fracture score is more than 3% and the other major osteoporotic fracture score is more than 20%, then definitely the candidate is up for osteoporotic treatment. Now, the next question comes is who should have a bone density test done? So a woman more than 65 years of age or men more than 70 years of age or younger postmenopausal women and men with age of between 50 to 69 years with clinical risk factors for osteoporotic fracture. And anyone with a low trauma fracture with more than 50 years of age needs to get a bone density scan done. Coming to the risk factors have been explained really well by Dr. Varun, but I'll just enunciate. They are age, previous fracture, a steroid therapy, tobacco use, excessive alcohol intake, secondary osteoporosis, family history of osteoporosis, low body weight, and rheumatoid arthritis. Coming to non-pharmacological management of osteoporosis, the patient needs to be given enough calcium and vitamin D. Patient needs to be counseled for good physical activity, which includes brisk walking or daily walking for at least 45 minutes. Weight-bearing exercises as tolerated and as per age. Smoking and alcohol to be avoided as much as possible, and to maintain a healthy weight. These are certain recommendations from the Bone Health and Osteoporosis Foundation, which they recommend at least 150 minutes of moderate, 75 minutes of vigorous activity per week, and strength training at least 2 to 3 times a week. So how much calcium is recommended? So the daily recommended allowance is around 1000 to 1200 milligrams per day. So these are some of the dietary sources of calcium-rich ingredients. So milk contains around 1 cup of milk contains around 300 milligrams. Your 1 cup of yogurt contains around 300 milligrams. Orange juice contains 260 milligrams, and 1 cup of broccoli contains around 90 milligrams. So these are some of the calcium-rich foods which can be advised to the patients. And while prescribing calcium supplements, make sure that at least 500 milligram of calcium is prescribed once, and it should not be taken more than that, because the body's ability to metabolize calcium is only 500 milligram at one particular time. If the patient needs more than that, then he should be prescribed maybe a 500 milligram dose twice daily. This is the recommended dose for vitamin D. It's around 800 to 1000 international units per day. In cases of vitamin D deficiency, we give a dose of 60,000 international unit once a week for 6 to 8 weeks, followed by a maintenance therapy of 1500 to 2000 international units per day. Another protocol of vitamin D fortification would be a 60,000 international unit per month dose, which is given in apparently healthy subjects with vitamin D deficiency. And vitamin D levels need not be checked regularly. We can wait for at least a minimum of 3 to 4 months to allow for the attainment of a steady state of vitamin D levels. Coming to the pharmacological management, there are two major parts of treatment of osteoporosis. One is the anabolic drugs. The other part is the anti-resorptive medications. Anabolic drugs are the teriparatide, and anti-resorptive medications are the bisphosphonates and denosumab. Coming to teriparatide, it is the only anabolic drug which has direct action on the osteoblast activity. It improves the bone architecture. The recommended duration is 24 months. But the disadvantage of teriparatide are it requires a daily subcutaneous dosage. It requires cold storage, and evaluation of serum PTH and calcium levels are important prior to initiation of therapy. Coming to the bisphosphonates, these are the most commonly used anti-resorptive medications. We have the oral alendronate, which is given 70 milligrams per week, or the IV zoledronic acid, which is given once yearly. So a drug holiday can be given in bisphosphonates, which is recommended is after 5 years for an oral medication and after 3 years for an IV medication. The drug holiday will not lead to a rebound increase in bone loss on stoppage of the therapy. And injection teriparatide can be used during the drug holiday. The side effects of bisphosphonate are renal toxicity, osteonecrosis of the jaw, and atypical femoral fractures. But osteonecrosis of the jaw and atypical femoral fractures are seen with long-term bisphosphonate use of more than 5 years, and the risks are very low as compared to the benefits offered by the bisphosphonate therapy. So the bisphosphonate needs to be taken properly, and the patients need to be counseled regarding the bisphosphonate therapy. It needs to be taken on empty stomach because it requires an acidic medium to act. The patient needs to sit upright for at least an hour, of not at least 30 minutes after the intake. It needs to be taken without any other medication, and the calcium supplements need to be taken at a different time. It is pertinent to note that alendronate is not effective against glucocorticoid-induced osteoporosis, and imandronate is not effective in men. Coming to the denosumab, it is a monoclonal antibody to RANKL. It reduces the survival of the osteoclast. It is a very safe drug. It can be used safely in patients of renal failure where bisphosphonates are avoided. The dose is 60 milligrams subcutaneously once every 6 months. However, on discontinuation of denosumab, there is a rebound increase in bone turnover and accelerated bone loss. So drug holiday cannot be given for injection denosumab. So this is the duration of therapy which is recommended. We start with the injection teriparatide, which is recommended for a 2 years of duration. We follow it up with an anti-resorptive medication, either a bisphosphonate for at least 1 to 5 years, or if bisphosphonate is not started, then a denosumab for at least 5 to 10 years, and then that needs to be coupled later with a bisphosphonate to prevent accelerated bone loss after the denosumab is stopped. This is an overview of the medications and their side effects. Yeah, okay. So take-home message is that osteoporotic fractures are serious but preventable. Lifestyle changes can slow but not reverse the bone loss. When used appropriately, osteoporotic medications are safe and effective. We need to identify the people at risk early and ensure compliance of the drugs. Thank you.
Thank you, Bhushan, for a very simplistic and nice presentation. At least it has enlightened most of the top medications which are taken routinely. And nowadays, a lot of combination therapies are being talked about in endocrinology and rheumatic societies. I just would like to ask Dr. Chhabra. Sir.
Yeah.
What is your protocol? Whether a lot of people are now, it's very, they are very happy with this denosumab because it is once in 6 months, Indian patient tolerates it well, results are comparable in various studies, but it's anti-resorptive, and teriparatide is something which is not anti-resorptive. So what is your take on these two molecules when you use which drug?
Normally, I would have used teriparatide for only severe osteoporosis, and WHO defines severe osteoporosis as a T-score less than -2.5 with a fragility fracture. So if you also go by the various guidelines as they grade, those at very high risk of subsequent fractures are to be given anabolic treatment with teriparatide. However, denosumab is also quite effective, quite efficacious, and very often patients either do not have a compliance to daily administration of teriparatide, or because teriparatide is a bit more expensive because it has to be given daily than denosumab. So very often in such patients also, because of patient preference or because of affordability issues, we have now been using denosumab with good results in those with severe osteoporosis. And since we need to give it twice in a year, the compliance is quite good.
I just want to ask, there is a lot of thing, and again, in various institutes nowadays, people are referring osteoporosis to the endocrinologist. Maybe I think it's good in difficult or severe cases, but what is the current status of this treatment in US, Shiva?
Yeah, at most quaternary centers or academic institutions, it is standard of care to refer patients to like a bone metabolic subspecialty endocrinologist if there's a diagnosis of definitely osteoporosis, sometimes even osteopenia. And so, honestly, it's probably a little bit overkill. I think there's a tendency to like over consult and refer, but that's standard of care. And so, especially for elective patients, say with the spinal deformity, older patient, and you're doing preoperative testing and you discover osteoporosis, then we will automatically refer to bone metabolic specialist, and then they will determine which medication to start, and then they will also sort of make the ultimate determination for how long the patient should be on that medication before considering surgery. So we really sort of defer to them.
Okay. What about you, Dr. Pillai?
Yeah, the osteoporosis, all the patients I would go with, depending on the severity of osteoporosis, I recommend a modification in their diet with adequate protein, vitamins, calcium, all those. Then regular exercise programs, muscle strengthening, bone strengthening, and cardio. And if the osteoporosis is severe, then according to DEXA scores, then I will initiate on teriparatide, and for 2 years followed by denosumab or alendronate or similar bisphosphonates.
Okay. What's there in Delhi, Dr. Arun?
So you asked one question to Varun in the beginning, when do you use DEXA? So in my cases, I use DEXA quite frequently to decide which patients to go for denosumab and which to go for teriparatide. So the ones which are -3 and have a history of more than 2 fractures, I would usually lean towards teriparatide. And the ones which are above that, then I'll be, for the sake of ease of giving the drug and compliance, denosumab is pretty effective. And it is pretty safe if for a wide range of patients where other drugs may be contraindicated. So that is one. You asked something more?
Like, whether there is a trend of asking the endocrinologist or rheumatologist for this treatment?
So usually most of my osteoporosis patients I manage by myself. Rarely, if ever, there is a mixed presentation, the patient is having some other metabolic disorder, then in that case, we may take an opinion from the endocrinologist. One thing I would add here is that the elderly ladies, which we commonly see for osteoporosis and we have to treat, even if we tell them to do exercises, they may not do it. So in my own practice, I just tell them to keep doing as much of daily chores as they can in their household. So it is like keeping them active to keep the bones loading. So perfect. That is one thing that I add.
Yeah, generally they say denosumab is quite safe and it can be given in most of the patients. Teriparatide, I think it's very important for all of us to understand. We have to check vitamin D levels, vitamin PTH. These two things are very, very important. Serum calcium, vitamin D, PTH, and creatinine. These 2-3 things are important when I personally do start the teriparatide, because when there is low vitamin D, you need to elevate the values and then start. It's very, very important. Yeah. Thank you, Dr. Bhushan, for a wonderful presentation. We move on to the next. I would invite Dr. Ahilan Sivaganesan from Philadelphia. Over to you, Siva.
Yeah, Shailesh, as the presentation comes up, I would also want to add that you very rightly suggested that vitamin D should be appropriate in these patients, but also we need to rule out any history of malignancy. And if at the slightest doubt, we should get a PET done to rule out malignancy, because it would be contraindicated in such cases.
Perfect. Perfect, sir. Yes, Siva.
Can you hear me okay?
Yes.
Okay. So this will be relatively brief. I don't have the preoperative imaging, but hopefully we can use this as an opportunity to talk about some sort of new adjunctive technologies. So this is just a quick case I'll show from about a year ago, where we treated a symptomatic patient with mechanical axial back pain from significant osteoporotic fracture with posterior screw rod fixation. We actually used robotic assisted pedicle screw placement for this surgery, and so I think maybe it's an opportunity to discuss the role of navigation and robotics in the treatment of these patients. Our rationale in this case was that if we have the option of using either image guidance or robotics, it gives us extra confidence in the accuracy of the pedicle screw placement, so that, and in this case, we used fenestrated screws to allow for, cement administration through the screws. But it really gave us the extra confidence to maximize cement administration. And on top of that, as everyone knows, whether it's image guidance or robotics, you can plan screw dimensions, both in terms of diameter and length, that really maximize pedicle fill and maximize sort of bony fixation, separate from the cement augmentation itself. So I'm curious whether, the surgeons on the panel think this is sort of, some may say it's a little bit unnecessary, if you are confident in your fluoroscopic guided, percutaneous or open pedicle screw placement, that this is not necessary. Others may say, yeah, it's a nice adjunct to have if it's available. So kind of curious what everyone's thoughts are.
Yeah. Can I just interrupt, Siva?
Yes, please.
Yeah, we have Dr. Chhabra, who has used robot, and Varun, who is using O-arm. We'll take their views. Chhabra, sir.
Yeah, I totally agree with Shiva in that. Accuracy becomes a bit of a concern when you go in for MIS procedures. And if you have a technology available and if you have access to it, there is clear-cut evidence that there is better accuracy. Two, it is not only accuracy. With MIS comes increased radiation. So with robotics, you reduce the risk of radiation both to the patient and to the surgeon. And there is clear-cut evidence that in such cases, there are less chances of complications, there are less chances of facet violations, there are less chances of revision surgeries. So overall, better outcomes with robotic, less duration of hospital stay. So if we have access to it, and if the patient can afford it, I think this is a technology which is definitely useful.
Yes, Varun.
Very rightly said, sir. I totally agree with you, and especially in these kind of cases where sometimes the collapsed vertebra, you are not able to make out the pedicles even. Even those cases, you are able to cannulate and put in your Jamshedi with the help of navigation or robotics or these, helpful technologies. So in this case, perhaps I would have even put some cement in the fractured vertebra, because that allows us, these technologies allows us, to judge where, we are placing our Jamshedi needle, where we are placing our screws, and even in some trajectories which are not possible on the fluoroscopy, that we can achieve that.
Yeah, I just would like to add, we have published our precious pedicle in osteoporotic spine, in European spine, and around 172 pedicles, and the accuracy was 99.6%. And I think that is very, very important. When we are using a longer screw, we can use these screws which are double cortical, you can go to the anterior cortex also. That's an additional advantage for these kind of difficult scenarios, because at times we don't get a very good hold. And if you get a good anterior plus, two cortex, that's a very good strength for the bone. And I think it is definitely going to come everywhere. Thank you, Shiva, because there is a big role these things.
Yeah. Two additional points I would make is that, as everyone knows, there have been some very good meta-analyses that have recently been published comparing robot-assisted pedicle screw placement to traditional navigation versus, open or fluoroscopy-based. And there is a significant advantage to robot-assisted screw placement on these meta-analyses. Some may say, well, a marginal difference, even if it's statistically significant, what does it really matter? But these patients where medial breach of a screw or malpositioned screw, the clinical consequence in terms of cement extravasation is so significant that slight advantage in accuracy, I think, becomes paramount. So I agree with everyone that I think if you have the technology available, it's good. It's good to use. And then secondly, also, my mentor at HSS, Shiraz Qureshi, is a very avid user of the robot. He now routinely places, even for non-osteoporotic patients, 8.5 diameter screws in patients. So very large screws, bicortical, maximum pedicle fill. I think that sort of extra robust fixation can also help. The downside, of course, is that you need to have a revision strategy. So if you ever have to come back and upsize the screw, there may not be much pedicle left. But I think those are some of the advantages of the preoperative planning that you can take advantage of with navigation robotics.
Perfect. Thank you, Shiva, for this enlightening robotic and navigation topic, because this is going to be the future and all of us will be needing it. I would like to invite Dr. Arun to share his case scenario. Thank you, Shiva.
Is my screen visible?
Yes.
So I'm not going to share cases, just adding on to the classification that was presented.
Yes.
I'm sharing my experience with using this particular picture as a standard for my plan of care. Many times we see in old ladies osteoporotic fractures, you see an innocuous looking fracture, you recommend feeling that the patient needs a procedure, but then the patient doesn't agree. And then at 2 months or 3 months down the lane, they come and the fracture is nicely healed. And then you have a similar looking fracture on an X-ray, and you feel that, okay, this can be managed conservatively, and 2 months down the lane, it just collapses like anything, and then the pain continues. So you wonder, is there a way how you can similar looking fractures, and then you can find out a way how they are going to behave. So this was a nice paper from Japan, published quite some time ago, but not very commonly. I got introduced it to quite late. So these are the 5 fracture patterns simply seen on X-rays. You don't need an MRI or anything else. So you can see these fractures. The upper 2 ones are the concave type and the dented type, which usually reflect of a good prognosis. And the 3 bottom ones are the swelled front type, the bow-shaped type, which is actually a combination of a concave superior end plate fracture and a dent combination, and then there is a projectile types. So I'll just show you a few examples. You see there's a simple dented fracture here on the side L1. So you can see a small dent, and it continues to heal very nicely without any intervention. Then you have a swelled front. If you see the picture on the front L1, the height is not lost. There is only a simple osteoporotic fracture. Just a few weeks down the lane, it collapses like anything. So if you see a swelled front in the beginning, you may not go ahead with a procedure right at the time, but then you will be a little more alert in following these patients at a relatively frequent interval rather than the conventional 3 or 6 weeks intervals that we may follow them. Now, this is again a bow-shaped fracture, as I said, which is a combination of a superior concave end plate fracture along with a dent. So in this combination, this is again likely to collapse more easily. So again, a candidate for a careful observation, and sometimes you can go ahead for an early augmentation in such cases to avoid doing a augmentation with screw fixation in future. And the third negative prognosis is for the projectile type fracture, where you see a beak in the upper or the middle part of the junction of the upper and middle anteriorly. These fractures again tend to go into non-union and further collapse of height. So these are the things which I employ very frequently in my clinical practice to differentiate from the ones which I am going to conserve very enthusiastically, and the ones which I am going to look at very carefully in the weeks when we are monitoring them, or sometimes quickly recommending a procedure to avoid a bigger procedure in such elderly people. So that's what I wanted to add from my side. Thank you.
Thank you. This is the words of wisdom. That's what I can say, because a lot of things at times, and we have seen patients getting treated for osteoporotic fractures, and sometimes the pathology comes as different. A lot of time we treat patients with conservative treatment, and there is a collapse and retropulsion and neurological deficit also. These are certain things which are not in anyone's hand, but this is a practice which helps us to understand there are possibilities that there can be a worsening. It's very important to counsel the patient well, explain and pros and cons of both the things, so that there should not be a problem. They also understand this is the problem and it can go this side or that side. Most of the time, 90%, I think, conservative treatment really works well. Thank you, Arun, for enlightening us with this. And we move on to the next speaker, Dr. Suresh Pillai.
Yeah.
Dr. Bhushan, can you please share the screen?
Yes, sir.
Hello.
Yes,
Next
Suresh.
slide, please. Good evening, all of you. It's a wonderful session so far. So it's a different perspective. Maybe I have done this case in 2005. This lady, 62-year-old lady, presented with, after a trivial fall, she had difficulty walking and buckling of her knees while walking. So she was evaluated for a pathological fracture as well, but it was the tests were normal. So shall I request the eminent faculty to comment on their way of how to proceed?
Yeah, so let's ask Shiva, Dr. Ahilan.
Yeah, sorry, I was on mute. So the patient radiographically has cord compression, but I missed, was there a neurological deficit as well?
Yeah, initially she didn't have. Then she was followed up conservatively, but subsequently she developed the deficit.
Yeah, this is a very interesting case. So, one option would be to do a transpedicular decompression and fusion to address the ventral cord compression from the retropulsed fragment. And then, either 2 levels up or 2 levels down for posterior, fixation and fusion. There are, another thought here to save fusion segments is to do corpectomy and place either a cage of some sort or autograft, and then to do a shorter segment of fixation, depending on the age of the patient. But I think in my hands, I would do a transpedicular decompression. I actually enjoy using ultrasound in these cases. Once you do the laminectomy and the facetectomies, you can use intraoperative ultrasound to actually visualize the ventral cord compression. And then as you decancellate and tamp the retropulse fragments forward, you can actually evaluate the adequacy of the ventral decompression with ultrasound to ensure that you have achieved the goals. Obviously, O-arm is another great adjunct there, where you can actually get a spin afterwards and ensure that the fragments have been pushed forward.
Yeah, perfect. Bhave, sir?
Yeah, for our settings, I think what he has said is transpedicular decompression, confirm total decompression, and then go for long segment fixation, because this is a quite old osteoporotic lady. I think that becomes a choice instead of doing anterior corpectomy. If we are supposed to do anterior corpectomy, then I would do in lateral position, and in same position we can put the screws or posterior percutaneous pedicular screw fixations.
Okay, Varun?
Sure.
So this lady, because of the neurological deficit, needs a decompression, that is for sure. In my hands, it would be more of an MIS anterior kind of an approach, an anterior corpectomy, and maybe a percutaneous pedicle screw fixation at the back, and with a cage supporting the corpectomy in the front.
Okay, Arun?
Chhabra, sir.
Chhabra, sir?
Yeah, I would go in posterior, all posterior, but I would do a corpectomy, and I would shorten the column and probably put in a peak cage in front after a corpectomy. I would go in for a long fixation, cement augmented, most probably. The DEXA is likely to be less than -3 in this patient for sure. So, but ultimately it depends on the feel as you put in the screws. But most probably we'll need cement augmented screws. And I would do a corpectomy. There will be definitely a dynamic instability if we do a dynamic MRI done in this patient. And this is a substantially unstable situation, which definitely needs a fixation and a decompression, whichever way you approach it. And
Arun?
of course, you have to start on anti-osteoporotics and on comprehensive osteoporosis management, which is very essential.
Varun? Sorry, Arun Bhanot.
Yeah, so see, this is only an MRI picture, and I would, before doing a procedure, I would definitely want to do a CT scan in this case. And if the I can avoid doing a corpectomy at this age, I would definitely look for the possibility. Though as of now with this picture, it looks corpectomy is imminent. But if there is a chance and the fracture does get corrected by positioning and you have a CT scan that shows there is some bone on one side, I would rather use that pedicle and bone to have a fracture vertebra screw placement and the other pedicle to put transpedicular graft or maybe a synthetic graft in that to reconstruct the anterior column and then do a posterior decompression, but all done from the back.
And Dr. Shailesh, what's your opinion?
No, I think at times I find it difficult to do a transpedicular decompression because that's a big fragment and it won't go backwards. Probably I will do a fasciectomy. I will do anterior plus posterior. Anterior reconstruction is important. Decompression also is important because that has to be achieved, and maybe 3 or 4 levels above and 3 levels below minimum.
So all the faculties are in consensus that the surgical intervention is needed. So there are different ways to bell a cat. So depending on which way you are familiar and safer. So I'll show you what I have done. Next slide, please. And next slide. Next slide, please. I went anterior and posterior. Anterior a corpectomy and a stud graft, and a posterior no laminectomy, only pedicle screw fixation. No, before that. This is a different. The slide, previous slide, yes. And as the anti-osteoporotic treatment was optimized, injections, everything was given, and she was holding on for 12 years without any subsequent fractures. And after 12 years, she died of some other reasons.
Okay. Nice.
Thank you.
Yeah. As rightly said, there are different ways to deal, and luckily she is a lean and thin lady, not very overweight, and you really did a good job. At times, you can actually, if it is a fresh fracture, you can actually get away without doing an anterior decompression. But that's the experience and the judgment which is required in neurodeficit cases. But yes, Shiva, any thoughts on this now?
This is a different case now, is it?
No, I'm not presenting in this case. I have finished my presentation on that.
Oh, I see. No, I think it's a wonderful result, and I think people generally think of corpectomy as more invasive, but if you do a corpectomy and then you save the patient from a direct decompression and you are able to fuse fewer segments, it's a less invasive procedure, and so I think it's a very elegant solution for this problem.
Absolutely. Perfect. Thank you, Suresh. We move on to the next case by Dr. Chhabra. Over to you, sir.
Just a minute, let me. You are seeing my screen, but not the slide, are you?
Yeah, I can see your screen.
You can't see my slide, right?
Slide also we can see, sir.
Right, fine. So, you can see the slide well now?
Yeah, perfect.
Right. So, this is we had this 59-year-old female who presented to us with weakness of right lower limb since 2 days and leakage of urine since 1 day. She had a history of a chronic liver disease with portal hypertension, hypothyroidism, and restrictive lung disease. And you can see that there was neurological deficit, more gross on the right side than on the left side, but also she had reduced perianal sensation, so consistent with the cauda equina syndrome. I'm sorry, I don't have very good images, but you can see that there was a osteoporotic vertebral compression fracture at L1, and which on a dynamic view you could see instability. On an MRI you could see the compression, and there was a neurological deficit along with it, so this was a case of an osteoporotic fracture L1 with paraparesis, with impending cauda equina syndrome, with chronic liver disease, with portal hypertension, with hypothyroidism, with restrictive lung disease. In fact, it was not impending, it was a cauda equina syndrome. So, Shailesh, what would be the challenges for managing this patient?
I think first challenge is the medical problem. That's a very important, we try to treat one thing, and at the same time, we have to keep an eye on what medically, how she will sustain if we are planning to do something. Optimizing her, getting a team involved, explaining the patient and family about what we are planning to do is very important in such cases, sir.
Very rightly said. So there was all those medical problems, and the anesthetist said, no way we can put her through general anesthesia for surgery in this patient, right? So you just nailed it, and this was a big problem. Of course, severe osteoporosis was another issue. The DEXA showed a T-score of -5.5, and we worked her up also in this regard. So quickly asking the panel, what would be your plan of management? Arun?
Sir, you've already listed the biggest challenge is the anesthesia and then the severe osteoporosis. Even when you decompress and fix, you are going to face an uphill task, but then that is the need of the hour. So the plan would be to do a long level fixation, but it has to be done in double quick time because of the multiple medical problems. So to keep the anesthesia time short, the choice is between a corpectomy and a posterior decompression. Given the medical situation, I would try to not go the corpectomy way.
Right. Sivaganesan, any thoughts on this case?
Yeah, I definitely agree. I think speed, time under anesthesia is paramount. So I would agree with the long segment fusion, direct decompression, and then off the table.
Right. Anybody has any other plan of management? Fine. How would you reduce the risk of implant failure due to osteoporosis? Fine. I would ask Varun.
I would, sir, look for cement augmented screws in this case, but like everybody said, anesthesia and time is a challenge.
Right. So various strategies which can be there: bicortical purchase, as Shailesh mentioned, wide diameter screws, PMMA or biodegradable, but cement augmentation would be the procedure of choice. And of course, you could also augment with tapes and other things which are there. Other than managing the fracture and the medical management, what other aspect of management would you advise? Of course, osteoporosis is something that we have to go in for. I will just ask a quick question. Dr. Pillai, what can be the consequences of not managing the associated osteoporosis other than implant failure? Suresh is there?
Yeah, he's there.
If not, maybe he's traveling. Dr. Bhave? So, Shailesh?
Yes, sir. There is a possibility of a PJK or PJF, fracture above. That's a possibility, because apart from this is one important thing I think we need to plan.
So I will quickly want to brief our colleagues, young colleagues who are in the webinar that because we have to also look into biomechanical consequences, the muscle fatigue and the sarcopenia which is associated. The kyphosis tends to also put a bending moment on the vertebra above and below, increasing the chance of their failure and vertebral compression fractures there. So the risk of another vertebral compression fracture is substantially if we don't treat it, and then the spine gets gradually bent over, and that leads to a shortening of the chest capacity, and that can lead to GI and respiratory symptoms. FEV1 may get reduced. The quality of life gets affected because there are restricted activities of daily living, increased incidence of sleep disturbances, psychosocial consequences which come with it. And also it has been shown that the vertebral fracture increases the risk of mortality if not appropriately treated. The relative risk of death following a clinical fracture in the fracture intervention trial, you can see that there is a 8.6-fold risk of death, and the lifetime risk of death as a result of fractures is equal to that of breast cancer. So you can see here in a summary the downward spiral that can take place if you do not treat these patients of osteoporosis. I'll quickly summarize what we did. We did a kyphoplasty of L1 with percutaneous stabilization of D12 L2, and this was done with cement augmentation, but all under local anesthesia. We did not go under a GA, and the patient had good results. We started with bladder management. Patient was evaluated for osteoporotic profile. Teriparatide was started, calcium and vitamin D supplementation, dietary counseling for protein-rich diet, and fall prevention were done. So we can, as Suresh previously also said, there are very many ways to bell a cat, but in this case, because our anesthetists were not brave enough and they said, no way, we would allow you to give GA to this patient. So we did everything, of course, under anesthesia, anesthetist care, MAC as you would put it, but we did the procedure under local anesthesia and we had good results.
Wonderful case, and actually a nightmare when you're planning for doing this case, and what will happen tomorrow is always a missing beat feeling for a surgeon. And whatever best possible option we need to think of, and what you did is a great learning for all of us, sir. Doing it in local anesthesia, minimum time, fixing short segment, doing a kyphoplasty, stabilizing anterior plus posterior cortex, decompressing, everything absolutely spot on. Any other inputs, Shiva?
Oh, I think that's a great result, and avoiding general anesthesia, very, very smart. Multiple benefits from that. That's wonderful.
Bhave, sir?
Yeah. Under local anesthesia, that is the best thing what you can offer to the patient.
Yeah.
So problems of GA and everything is minimized.
Yeah. Suresh?
Yes.
Arun?
There was a little connection problem. I couldn't see the whole thing, but I understand it was a minimally invasive surgery for GA contraindicated patient. Excellent, sir.
Yeah. Varun, anything from you?
Yeah, so it was an excellent done procedure, sir, and we should, learn, take away from this is that even things out of the box thinking of a local anesthesia, placing the screws can really help the patient with this.
We have been doing kyphoplasty under local anesthesia since a long time now, because that is helpful in that if there is any deficit, the patient can, or if there's any pain, he can tell, he can inform you at that time. Plus, with a grossly osteoporotic spine, putting in screws is not a challenge. It goes in easily. So we were able to manage in this patient this way.
Yeah, very nicely done, sir. And I think there are a lot of things which really can be talked about in a webinar, like a vertebral body stenting, vessel plasty, what Dr. Bhave is doing, a heart shield, which is also a very good implant for long fixations with a strong lamina. Kyphosis correction, the adjacent segment disease, proximal junctional failure cases. There are so many things which can be discussed, but I think probably we'll have to do one more session on this
recording stopped.
Remaining cases. Thank you, all esteemed faculty and our viewers for giving us a great time and looking forward seeing you once again. Thank you, Chhabra sir and the Advocacy Committee team for from ASSI to give us the great opportunity. Thank you once again. Thank you.
Thank you. Thank you.
I just want to put in one last word, Shailesh. I think on this World Osteoporosis Day, we should point out, especially to our young colleagues, that still in India and in other parts of the world, more than 80% of patients who have osteoporosis and who have a manifestation which is so evident that it is osteoporosis, that is a fracture, they still go untreated with osteoporosis management. So like hip fractures not being treated for osteoporosis, but just for the hip fracture. So there is a very high rate of underdiagnosis and undertreatment for osteoporosis. And we should all pledge that we should take the earliest opportunity to start on comprehensive osteoporosis management for these patients, other than just stabilization of the fracture. And that message should go out loud. And that is one of the reasons why in India, we probably should not be advocating endocrinologists to be roped in for every case. The orthopedic surgeon is capable, the spine surgeon is capable of managing osteoporosis and should use the first opportunity of starting the treatment. And very importantly, counseling on the importance of comprehensive osteoporosis management so that the patient is compliant with it. That is very important. That was just the message I wanted to give.
Thank you, sir, for this. And we are planning for the second episode in the month of December on injury prevention and again osteoporosis. We'll club it to our webinar. We will be in touch with you all, esteemed faculty, and Dr. Siva giving us great time from the US. Thank you once again, Ahilan, and everyone, Chhabra sir, and all of you. Thank you very much. We catch up again.
Thank you. Thank you.
Good night. Yeah. Bye, sir. Yeah, Ashok, thank you.
Sure, sir.
अशोक, अरे त्यांनी पहिलेच रेकॉर्डिंग बंद करून टाकलं.
Thank you, Shailesh. Streaming is going on.
Okay. Perfect. Because I thought it is,
Streaming, I just stopped it.
Chhabra sir was giving the message. Yeah, perfect.
No, there is no issue with streaming.
Yeah, thank you very much. Yeah. Thank you, Ortho TV team for a wonderful support, and we connect again. Thank you.
Sure. हम ही लोग है, कोई नहीं है और